Johnson. I'm the executive director of MedVR. MedVR is a medical XR accelerator. We've been in operation for a few years in this incarnation. Executive director. Our focus is to accelerate and enable medical innovators that are interested in applying medical XR. We've held well over 40 talks, all of them with a constant theme. The theme is the journey of the medical XR innovator, which is a little bit different than you tend to see. We are a nonprofit educational corporation located in Boston, Massachusetts. We have a talk coming up in 2 weeks that I'd like to tell you about, which is, let me just pull it up here for you. I'll share my screen. So the okay, here you'll see our talks page and all the many talks that we've given over time. Coming up in 2 weeks is using immersive VR support groups for young cancer patients. This should be very interesting because we have both technical people as well as clinician who are talking about the translational process of applying this technology in a new area and in a different setting. And we'll have expert speakers. Asha Marks, who's at Yale University Hospital, and Dor Goldberg, who is with the Glimpse Group and Foretell Reality that built and adapted the product. Shauna, that's an area you're not you won't be moderating that talk. So with that, I'd like to introduce our moderator, Shaunak Bakshi. He is a resident physician at the USC Roski Eye Institute of ophthalmology at the University of Southern California, and an incoming fellow at Mass Eye and Ear, Harvard in the cornea and refractive surgery area. He received an MD from Harvard Medical School and a BS from Yale College. He's been involved in MedVR since its inception and has worked on multiple projects of applying extended reality in healthcare. He has a deep interest in the development and application of technological innovation at the bedside and has published a wide range of subjects from the keratoprocess, artificial cornea, and I should have practiced this beforehand. Presbyopsia, correcting technology and applications of artificial intelligence and virtual reality in healthcare. He has a background in both clinical research and translational bench research. So with that, I'll turn things over to you, Shaunak, and looking forward to this talk.
Thanks so much, Steve, and good morning to everyone from California. It's a pleasure to be here and a pleasure to be moderating this talk. And we're going to go ahead and introduce our speaker for today, Dr. Matthias Abeg. He's a clinician and ophthalmologist who received his Doctor of Medicine degree as well as his PhD from the University of Zurich. He then completed fellowships to specialize in the fields of strabismus surgery, neuro-ophthalmology, and pediatric ophthalmology. He is clinically a special interest in eye movement disorders. His scientific interests include clinical eye movement research, maculopathy from optic neuropathy, as well as electrophysiology of the visual cortex. He serves as medical director and co-founder of MachineMD. He is also co-founder of eBovis, an interesting model for automated comprehensive eye examinations, and he'll be talking a lot about this work today. He previously was head of the orthoptics department in the University Hospital of Ophthalmology in Bern. So today he'll be speaking about his work utilizing VR headset technology for diagnostic applications in neuro-ophthalmology. Looking forward to a very interesting discussion. During the talk, please feel free to include any of your questions in the Q&A section so we can address those after the talk. So I'll turn it over to Dr. Abeg.
Thank you very much for the nice introduction, and thank you for the invitation. It's a pleasure to be here. It's night and winter in Switzerland already. So wonder how the weather is in California. I'll be talking about how VR can be used in a meaningful way, namely to identify brain disease. A bit of introduction of myself, mostly by my conflict of interest. You mentioned that already, and this one is important for this talk. I'm co-founder and shareholder of MachineMD. They develop a product called NEOS, and that's relevant for this talk. So bear in mind, I might have a commercial interest in what I say. I have an affiliation with the University of Zurich. eBovis is not so relevant for this talk. Most of my working time I spend in a medical practice here in Bern, Switzerland, where I see patients, mostly pediatric patients and patients with brain disease affecting the visual system. So while preparing for this talk, I wondered, what's the fuzz about VR? Well, this is me sitting in front of my computer this morning. Why should I now switch to a VR headset? Well, there is a difference, maybe. Once you put a VR goggle on your head, it allows you to immerse into a world. And the difference between me in front of the computer and a person wearing a VR goggle is they have a larger visual field. So maybe they can even turn their head to look around, and they have a stereo vision. They can perceive depth. Field of vision, or visual field, we call that in clinics. And stereo vision, that's my business in my practice, because this is what I do. People or patients come to see me, as this girl here, because of a deviation of the eyes. And once one eye is turned in, patients lose stereo vision, so they can only look with one eye, and the other eye, if anything at all, is more disturbing than helping. Then we can do a procedure. In this case, it was a Botox injection to align the eyes, which is a good idea. The goal of such an intervention is to restore stereo vision and maybe to enlarge the field of view, because when the eye is turned in, the visual field is somewhat narrowed. Now you wonder, what do these patients here with strabismus really complain about? And I can tell you, I have reservations that the visual field is so important. I have a lot of reservations that stereo vision is important. The patients, they don't really complain about either of the two. They complain about the social contact and many other things, double vision, for example, but stereo vision and field of view in my personal clinical practice is not so important, especially stereo vision. You can do any profession almost without stereo vision. I even know a professional hockey player that has no stereo vision at all. So it's not the most important thing in the world. When it comes to visual field, where it really counts is when you run through a busy train station, for example. Then you need it. But when you're sitting on your chair with a VR goggle, maybe visual field is not the single most important thing. So it's not all that obvious, the advantage of wearing a VR goggle as compared to a person sitting in front of a flat computer. So that's the introduction to catch your attention. So in my view, VR is mostly used for consumers. They look into the goggle and experience maybe a nice virtual reality. So the wearer looks into the glasses. As a neuroscientist and as a clinician, I try to do it the other way around. I try to use VR goggles to look inside the user, or in this case, the user is a patient, to learn something about how the brain functions. And how this is possible, I try to show on this slide. This neuroscientists look into the brain. In a clinical context, we call this neuro-ophthalmology, and this is what it is about. Visual information is projected through the cornea, which is the field of interest of Schoenack, through the back to the back of the eye, where the information is transformed into an electrochemical signal, which is then transported into the brain, all the way back to the visual cortex. From there, it is distributed over the brain. Interesting things are selected. This information is then transported to the brainstem, where eye movements are programmed, and then the cranial nerves send the information back to the eye. And the eyes are jumping around, or the pupils are getting bigger and smaller. So these cables that cross the brain for the afferent part, so for the visual information to arrive in the brain, and all the cables and nerves and nuclei that come from the brain to go back to the eye, to the pupils and to the eye muscles, they go all across the brain. So whenever something breaks somewhere in the brain, the chance is high that it has an effect somehow on the visual system. And if you know how to look at that, you can find out what in the brain is broken. And this discipline is called neuro-ophthalmology, and it is not my invention at all. It is a long traditional clinical field. There are books like this one, the reference book, 3 large volumes on how you must look at the eyes, how you need to examine the eyes to find out which part of the brain does not work properly. So there is a long tradition in ophthalmology, in eye medicine, how this can be done. And it is important because many brain diseases affect the visual system somehow. I just put here 2 examples. So one inflammatory disease of the brain called multiple sclerosis very often has a sign at the eye. So maybe the pupils don't react as they normally do. Or the eyes don't jump as they normally do. So many patients with multiple sclerosis, they have a symptomatic or asymptomatic sign as at the level of the eyes. Another example are brain tumors. Many brain tumors, depending, of course, where they're located, affect eye movements or vision somehow. So we're not talking about rare diseases. And this is how neuro-ophthalmology is being done today. You need a flashlight, a fixation object, and a cover tool, and a prism bar, and then you shine light into the eye. You have a patient follow an object, or you cover the eye. And this then allows you to find out what is not working properly. You can see that in almost any doctor series on television. How the pupils are examined, for example. That's a classical neuro-ophthalmic examination. If you want to do a complete workup, rough estimate, that takes about 45 minutes, and it takes a long training to be able to do that properly. For me personally, only after residency, only after fellowship, and really honestly, only after a few years after my fellowship, I felt really competent in making these examinations reliably. So it takes time and it takes training to do these examinations. There is a shortage, at least in the US, apparently. I don't live there, so I don't know firsthand, of people who are able to do neuro-ophthalmological examinations. Apparently, the median waiting time to get access to a neuro-ophthalmic exam is roughly 200 days. And no wonder then that in the first place, a lot of wrong diagnoses are made in the field of neuro-ophthalmology. So we thought, how can this be solved? There are these VR headsets now increasingly on the market. They allow to display things. So rather than using an object to move around, we can display something in the virtual reality goggles. Many of those are equipped with a infrared camera that films the eyes, and this infrared camera then allows to do eye tracking. Eye tracking means you can determine the position, so where looks an eye at a given time point. A side product of eye tracking is always pupil tracking. So it mostly or very often or normally also tells you about the size of the pupil. That's something you need to find out where a patient looks. So we use these eye trackers and pupil trackers combined with VR headsets to create a tool called NEOS. And here I have this financial conflict I was talking about initially, that does what we call full neuro-ophthalmic exam automatically. The advantage is you don't really need the skill to do the exam yourself. You just hit the button and then it runs it for you. So this allows any user to do a proper neuro-ophthalmological examination. It does not really replace a neuro-ophthalmologist, however. You still need someone who knows how to read the data, at least in this first version of the device. So it makes this neuro-ophthalmic exam accessible. It is automated and it makes it more quantitative rather than qualitative, as is the manual examination today. And this hopefully contributes to improved accuracy. This sounds maybe very abstract to you, so I thought I bring you an example. That's a patient whom I've seen a couple of weeks ago in my practice. He has had a stroke, and the neurologist told that he has a complex eye movement problem. I'm not sure whether you can see the video okay here. It's not working very nicely. Anyways, this is the look of the VR goggles onto the patient while he follows objects or while a screen is bright or dark. And then you can try to find out what's wrong with this patient. Well, this tool does an automatic analysis, and it tells you that there is a misalignment of the eyes. Not both eyes look in the same direction. In fact, it is the right eye looks a bit higher up as compared to the left eye, and this does not change in the different directions of gaze. This is what we call a skew deviation, a vertical misalignment of the eyes. Then we shine light into one eye, and when we shine light into the right eye, nothing happens with the pupils. When we shine light into the left eye, both pupils react nicely. So the left pupil reacts to light and the right pupil does not. Then we check how quick do the eyes jump left and right, and how quick do they jump up and down. So here the eye is looking to a left position, then tuck, it changes to a right position. These movements are among the fastest a human body can do. And we measure the velocity of this movement, and we find, these eyes, they move fast to the right, they move fast to the left. However, up and down, and this you can even see without the quantitative analysis, when the eyes move down, they go slow. So there's a slow downwards movement, and they move slowly upwards. This is something I have clinically missed. I could not see that clinically because whenever the patient was supposed to look upwards, he was blinking, but the eye tracker could catch at least a few of those, and found that up and down movement is not working properly. And that would be the time point where I asked the residents, in this case Shonak, where is the problem? Only rhetorically, of course. And then Shonak would respond, I know. There are brain centers that are responsible for up and down gaze. This is called the RIMLF, the rostral interstitial nucleus of the medial longitudinal fasciculus. There is a brain center that's responsible for the integration of the balance system into the alignment of the eyes. That's called the INC. And in between, there are the pupillary areas where pupils are guided. So looking at such traces, I know they look a bit strange to you because you're not used to that, and neither am I, but we will get used to this in the future, hopefully. But looking at these traces, we know for sure something is broken down here in the brain. So that's and this then allows to make a diagnosis called Parinaud's syndrome or dorsal midbrain syndrome. So that's just an example of such a neuro-ophthalmic examination, and how it's then clinically used. And you may find this very academic, and it is somewhat academic. In this particular patient, nothing changes with knowing where the lesion has happened. But in very, very many patients, lesions, especially in the brainstem, are not picked up by magnetic resonance imaging. So it takes a clinical examination to find out where is the problem. Then you wonder, yeah, well, how valid is such an examination? And there we have the beautiful advantage that there is a long tradition of eye movement recordings. It's not our company who has invited eye movements, and not eye tracking neither, but when you type into PubMed, you find 12,000 publication on eye tracking, and there is a whole science on how eye movements are working and how they can be clinically used. The reference book for this one is the Neurology of Eye Movements by David C. So there is a lot of knowledge on the market already, and with a good eye tracker, we can tap into this knowledge. So I don't go into any detailed validity studies. I just show you one single, because this is a very important exam. Oops, I hope I need to switch off the sound. So this is the examination I was talking about. You see in any doctor series, a doctor shines a flashlight into the left eye, then into the right eye, and then into the left eye, and checks on the pupillary reaction. In this case, you see the right pupil does not respond very nicely as compared to the left pupil. Those who know, you can use filters to quantify how big this difference in light reaction is. This, along with visual acuity, along with a visual field examination, so these three things are the cornerstones on which any defect in the afferent visual system is based upon. Visual acuity, many people are capable of measuring that correctly. It's not easy, but it's possible. Visual field, there are standardized examinations how you can test this. When it comes to the pupillary reaction, there are a lot of false positives. Some people without proper training doing this type of examination, they get it about in 50% right. So it's almost guessing. And even in experts' hands, the sensitivity and specificity is not that great. So we thought this is a really important one to check. So we did a study using a different device, not ours, but in the FOVI. So another experimental device. We shine light into the right eye, into the left eye. We measure the pupil response, and when you look at the trace, here light is in the left eye, and here light is in the right eye. It takes no PhD to recognize that there is a difference between this part and this part of the curve. So it's easily quantifiable. We checked in how many patients? Roughly 60 patients. How good does an automated analysis pick up disease? And we found that this device, and to my colleague who is also an experienced neuro-ophthalmology, performs roughly just the same in terms of sensitivity and specificity. So the device is roughly equally good as me as a neuro-ophthalmologist. And this even is a very unfair comparison, because me as clinician, I have talked to the patient. I know already quite often what their problem is. The device, however, is ignorant. They don't know anything except for the pupil. So my fear is, or my hope is, I don't know, that the device is probably better than a clinician in measuring the deficits in pupillary reaction, which we call relative afferent pupillary defect. So this is where we are today with this device. I'm unfortunately, I haven't brought my watch, so I don't know how I am with time. Okay.
Yeah, we have some time.
Perfect. So using a VR device with integrated eye tracker, already today we're able to do a more or less comprehensive neuro-ophthalmological examination using a device. And this then allows to either identify a disease or maybe to monitor a disease. We were also wondering, and that's not, and there we're not, so now I'm talking about the future, what about brain disease that do not primarily affect the visual system, such as the MS and the brain tumors example I was talking about. There are many other areas in the brain which may not so much affect the visual system, or the kind of patients I don't see in my practice usually. And here's a non-complete list of such diseases. There are a few important ones. Neurodegenerative diseases, especially Alzheimer's or Parkinson's, but also others, are not primarily neuro-ophthalmic diseases, so they don't go to see an eye doctor usually. Same is with trauma, which is important here, and also in the US, I understand. So people after a concussion quite often complain about problems, and it's not quite sure or clear what is broken in their brain. There are metabolic diseases and genetic diseases, so many of those. We will not go to each one of those. But I show you an example of how this might work in the future, how you can use eye movements and pupil movements maybe to identify also such diseases which today are not diagnosed at the level of the eyes and the pupils. And here's the exception to that rule. So I saw a patient really just a couple of weeks ago. She was referred for a nystagmus. I'm not sure. Can you see this video okay? That would be nice. And the problem was her eyes are not steady. So she looks onto an object, and then they jump off and jump back on. Jump off, jump back on. She feels dizzy when walking, and she has some mood disorder, or that's the interpretation of the general practitioner. He thinks she has a depression, and she does not agree, by the way. And when I examine her, and many other doctors she has seen before examined her, everything looks just normal, except for this piece. That the eyes jump back and forth. So we have a look at the recording of this patient, and what we can see is every once in a while she looks onto an object, all of a sudden both eyes jump off the object and then jump back on the object. This is known. This is called a square wave jerk. It's not a nystagmus. It's a problem of holding your gaze onto an object. It has it does not help very much, so it's not normal if you have a lot of those. Sometimes it tells you that you have Parkinson's disease, or we call that extrapyramidal disease. Sometimes it's a problem of the cerebellum, so the motor part of the brain. When we look at the rest of her examination, she also has this same problem we just seen before. The eyes jump rapidly, horizontally, back and forth, but she has clearly very slow up movements and down movements. Here again, in her up, when she looks up, she uses blinking to overcome her deficits in moving the eyes up and down. And already before, you learned when up and down does not go well, there is a problem at the RAMLF, so the piece of the brain that's responsible for programming up and down movements. So you take these two things together, a lot of square wave jerks and slow up and down movement. There is, in my view, only one diagnosis that qualifies for this, and that's called a progressive supranuclear palsy. That's a very special kind of Parkinsonism, which is devastating because it has a fast progression and it cannot be treated. This patient, however, she has not this diagnosis because she's she came too early, and we know too much. So her clinical routine did not allow to establish this diagnosis yet. So this is an example of maybe how in the future a neurodegenerative disease could be picked up in the eyes. And when you look through these diseases and through the medical literature, you find that actually a lot of those, or in this particular list, all of those have eye signs or pupil signs that have been described in the literature. So, for example, and I stop with this example, people with normal Parkinson's disease, so not the special kind I just showed you before, they have abnormalities in the great majority of patients. Some people think that eye signs are useful to early detect the disease. It affects fast eye movements and slow eye movements, and it affects the pupils as well. And one idea we follow on a research basis, that's my affiliation with the University of Zurich, is we try to find out how good are we in picking up such a disease like Parkinson's at the level of the eyes. And I don't have the answer yet. So all is covered here. What says this slide? So I showed you that today, or that's at least my perception, VR is mostly used on the consumer side to experience something or to get into something, or to look at a world. We looked the other way around, and we are interested, in some other companies, by the way, we use this technology to recognize brain disease. Maybe you can even use this to allow treatments of disease. And one thing I have not talked about, but which is maybe very big in the future, is how you could use eye movement responses to visual scenes to measure cognition. So today's use of VR, where we look into a virtual reality, may fade away. And maybe VR will be more successful in looking in the other direction, VR into the brain. That's my take on this, or I would bet my money more on the second case. I have bet my money more on the second case, actually. So I thank you very much for having listened to me, and I say danke schön. And I'm open to questions if there are any.
Great. Thank you so much, Matthias. I think it's just really fascinating work. I think when I think about the field of neuro-ophthalmology, you think about a nuanced, sort of very intricate exam. It takes time to learn, takes time to perform. And really, as you were sort of mentioning, particularly in the US, there are areas in which access to care is such a huge issue. Patients have a long time getting in to see the neuro-ophthalmologist. There are many areas in which there just aren't enough subspecialists available. And so there's a huge need for better solutions for more efficient sort of care, diagnostics, therapeutics as well. So very interesting. And, I'm curious, how you imagine deploying this kind of, the Neo solution in the clinical setting. I mean, there's such a wide range of applications. Would you imagine this being perhaps a screening tool, even in primary care settings or emergency departments, given that there are a lot of conditions, as you mentioned, that are not just primarily neuro-ophthalmic conditions? Or would you think it could be used in sort of the optometry and general ophthalmology setting? Or perhaps beyond that, even in neuro-ophthalmology offices to improve perhaps efficiency in data collection, given that there are so many patients that are in need?
So we dream about all of those examples you just mentioned, but primarily we would wish that our device or some device that does that is found in any ophthalmological practice primarily, and in a neurological practice. So our take is we give the expertise or the capacity to do such an exam to any ophthalmologist and any neurologist. So you specialize in cornea, and of course it's to measure an alignment of the eye. Maybe today you're still perfectly capable of doing that, but in 10 years from now, you will probably not, because you don't do that every day. And yet your patients, they are also strabismic. And so you can have that examination in a standardized quality, even if you're not so much interested or specialized in this particular field. And given the lack of neuro-ophthalmological expertise, that solves hopefully a lot already. And really, we imagine that this device is being used like the visual field, the Humphrey or octopus, it's called here, or like the autorefractometer. So it's another tool that completes the ophthalmic exam. And only later, maybe, but even there I'm skeptical, it may also make sense in different practices, even in primary care. But there it's about screening, and screening is a difficult issue. As soon as you start screening the diseases, you will find false positives and false negatives. And in my view, we would really need to do very good, powerful clinical studies not to create too many false positives. I'm a neuro-ophthalmologist. I see here in Switzerland, whenever people have a problem, first they go into an MRI scan of the brain. And there they see here a white dot, there a white dot, there a little tumor. And then they're sent to me. So I see a lot of false positives. And I wish us as company, we don't contribute to this explosion of chasing false positive results.
Right. Yeah. Along those lines, we're getting a couple questions here about, you mentioned applications in neurodegenerative disease, for example, like Parkinson's. A couple people are curious to know, what you think about applications of, eye tracking solutions in terms of monitoring development and progression of neurodegenerative diseases over time, things like Alzheimer's, or even sort of MS, Parkinson's, that kind of thing. And also actually
Yes.
monitoring them as they're being treated.
Absolutely. These diseases, how they're monitored today, either there is an anatomical marker like brain volume or things, but on the function side, it is a very coarse, if a measure at all. So mostly it's the subjective impression. So patient tells it has gotten worse. I talk to the patient, I say, yes, I think he has more problems understanding what I say. And then you say it's worse. But this is far away from a quantitative measure. And the beauty of eye tracking, and that's how our company started, and that's what I used in basic research. It's quantitative, so anything you measure. You can have a numeric data, which then, of course, allows to measure a disease progression, hopefully much more accurate. But just to say that again, we don't diagnose Alzheimer's disease using VR, and we are not there yet, and nobody is, as far as I know, and there will still be a long way to go. But even for the basic neuro-ophthalmic problems, so like the pupil, for example, that's just not quantitative as it's mostly being done today. Now we have it quantitative, so now we can use it to monitor treatment.
Right. Along the more sort of technical lines, we have a couple questions here. People wondering which HMD, which head-mounted display are you actually using for the Neo solution? How did you actually go about selecting this? And also, there's a question about more about standardization. So, you mentioned that the Neos is able to collect this data automatically. Is there actual inconsistency, discrepancies between in tracking data across different VR platforms that have perhaps a different sort of variable video quality? Just wanted to see if you could shed a little bit more light on that.
So you wondered why we chose our device over others.
Right.
Initially, when we started, there was no device on the market that was sufficient for our clinical needs. What we need is a certain speed of eye tracking, because we also want to measure these very rapid movements. So we need a high frequency camera, so at least 100 hertz or preferably more. And then we need a large enough visual field. And we need to have access to this device. So we need to read the pupil data and we need to read the gaze data. And these devices, they have just come on the market. And the one we are using, I mean, we didn't build our hardware on our own. Thanks God. That's a very difficult task. We use Vario, which is a startup company from Finland, which has in our view, a beautiful device with a rapid camera, a reliable eye tracking, and even a nice high resolution screen.
Right. Yeah. Beyond this, actually, on a larger scale, sort of thinking about the big picture, you are someone who's served as both a clinician, you're also a technologist who's working in the startup world within ophthalmology. And we talk a lot about bridging the gap between developers and end users. You know, a lot of the people in our audience are people who are perhaps working on currently or looking to implement solutions in the clinical setting. So you're curious to know what challenges you've encountered in trying to apply this kind of tool in the clinical setting.
Yeah, there is a big challenge. There are engineers and they talk engineer. I'm a doctor, I talk medicine, and these are two different languages, apparently, and it takes a lot of care and time so that we understand each other. And once you found a common language where both sides understand each other, then it is very beneficial, because engineers, I think they can do things I can only dream of, but they completely ignore the patient or the clinical side, and it's the other way around too. So that's the main challenge in my view, to find a common language where you really understand each other. I get very quickly lost. I mean, now I get used to this a little bit, but you use an acronym HMD and takes me 1 second to figure out that you mean head-mounted display, and that's technical language. And I'm a clinician. I'm not familiar with this technical language, and there is much more. Now in coding and software development, that's a world I have not known before.
Right. Yeah, definitely. I think there's a lot of work to be done many times to sort of communicate on both sides, both in terms of the developer and eventually, in this case, the clinician who's going to be implementing any kind of new technology. There are some questions that are, along the lines also of cost. So we talk about any new health intervention, any new device or technology that comes out on the market. In terms of being adopted, one of the issues really is what is the cost of the device, of using it, of getting it into the clinic, versus the benefits in terms of outcomes or other metrics. It might be a little early to know, but has your group thought about the cost of implementing the solution? How much would this actually cost the system in general?
Yeah, only that's another field where I'm not particularly competent. That's marketing. But yes, I mean, we are entering the market. This device is very close to be finished. And the cost, I mean, the price for the device, or here in Switzerland, you buy a device, you pay a price, and that's it. And that's about 45,000 US dollars. But then there is also different price models, and this may change in the future. If that was the question, or if you mean healthcare costs in general, we hope, but maybe we're cheating ourselves with this. But of course, we would hope that our device helps reducing healthcare costs, because when you know what kind of eye movement problem you have, you don't need to do imaging in every patient. Imaging, I mean, MRI scans, which are very costly around here anyways. And so hopefully the diagnostic workup is more targeted and being used more efficient, and hopefully this reduces costs. But when I look at the history, many devices have come on the market with the same promise, and eventually you then maybe pick up more disease. And I'm not all that sure that it's really reducing healthcare costs globally. Usually it does not. Any progress makes only everything more expensive.
At least in the short term, yeah.
Yeah.
In general, what do you think? There are a lot of questions around, you've talked a lot about the potential benefits of virtual reality, VR headset technology in terms of applications in identifying neurological lesions, locating the lesion, identifying their cause. What do you think fundamentally are some challenges with using VR headset technology in this space?
What are difficulties
Yeah.
well, the same difficulties as with any diagnostic device: false positives and false negatives. So you may get it wrong using this. That's the main challenge. So now, as of now, we are a very simple measure device. We only measure, and then the clinician looks at the traces just as we did together before, and then it's on the clinician who gets it wrong or right. But eventually, of course, we want to give normative data, and we want to tell the clinician this is normal and this is not normal. And as soon as you start to do that, you will also get it wrong every once in a while. That's, I think, our main problem. And then there are a lot of technical problems that need to be solved still, because you can make this examination probably much faster and more efficient and maybe even more reliable than we do it now. So there is still room to improve this examination for certain.
Right.
We were speaking about
Yeah.
So we were speaking about healthcare costs. This other company, Ebovis, so if anybody is interested, it even is in English, the homepage. There we try to reduce healthcare costs altogether by making not only the neuro-ophthalmic exam, but the entire eye exam apparative, which then allows like an industrial application of ophthalmology to a patient. Maybe that's a bit of frightening idea, and but it, in terms of just medical viewpoint, it allows to bring good medicine with much more efficiently to a patient, we believe. But that's the startup company too. Yeah. No, you're asking something else.
Yeah, no, absolutely. As a follow-up to the other question, many people are curious about how long it's taking you to actually, from scratch, develop NEOS and sort of get to where you are in your current state.
Oh, initially I was a brain researcher, and I just used eye movements to figure out brain circuitry and how things are programmed. And there I realized, the eye tracker is actually much more precise than me as a human being to detect speed of and precision of eye movements. And then at one point I wondered, why the heck isn't there a device on the market that I can use as a clinician? And then from that moment on, where I said, okay, there is no device on the market, we need to make it ourselves, until today, it's about 7 years. But real companies, so with investors and spending, and it's roughly 2 years where we worked on this. And before, it was research and thinking and discussing a lot.
Right. So definitely a long process from sort of conception, development, and sort of eventually to getting it out there in the clinic, right?
Maybe for the audience, I mean, one thing I did not know, or it took me a while to understand, the device as it is today, it's been in my head and even in the lab 3 years ago already. So it has not changed really. It's the same thing, but from a lab prototype, which does everything just roughly the same as the device today, to a clinical product, that's a very, very long and very, very complicated thing to do, and it takes many people to be able to do that. It's there is a lot of regulatory. It's so to create a product, to create a prototype, relatively easy. To create a medical product, I would say that's very, very difficult for me, anyways. And I haven't done it. There's people who do that for us.
Right, definitely a very long and complicated journey, but we're looking forward to seeing sort of how NEOS progresses. It's really fascinating work. It's really a pleasure having had you on today for our webinar. And yeah, we were looking forward to see what the next steps will be for NEOS and Machine MD.
Yeah, hey, thank you very much for having me.
Well, I want to thank you both, Shanak and Matthias, for this session. This was fascinating, and it's something that Lars Riedemann from UNI Heidelberg Hospital and I have talked about, saying somebody is going to do this. And it's really wonderful when you see something like this happen, where this technology, this general purpose platform, has been able to be applied to creating a diagnostic device. So this is really wonderful. Thank you for joining us and giving a wonderful presentation. The recording will be up in a few days, so if you want to go back and go over it or share it with someone, please do. And again, stay in touch with us either via our website or by signing up for our mailing list. We have 2 or 3 talks a month. They're all on about the medical XR innovator's journey. Today we're doing neuro-ophthalmology. Next time we could be doing psychiatry, and the next time surgery. So you'll get a really good insight into the taxonomy of medical XR. So again, Shanak and Matthias, thank you so much for joining us, and to our audience for joining us. We look forward to seeing you in a couple of weeks. Take care.
Thanks.